All right, we are back for the fourth and final video covering the gold standards for COPD exacerbations. So, in the fourth video, we're going to cover it's going to be about rehabilitation, education, and self management. So, we're going to go over pulmonary rehabilitation, symptom control, oxygen therapy / ventilatory support, and surgical intervention. So, first off, pulmonary rehabilitation. Let's go over the benefits of pulmonary rehab first. You're going to see symptom improvement, fewer exacerbations and hospitalizations, and improved quality of life and ability to perform daily tasks of living, improved mental health, and less fatigue. So, then also, on the other side, what does pulmonary rehab consist of? Exercise programs, education programs, breathing retraining, chest physiotherapy and airway clearance, mental health support, and then behind my head it says nutrition. You just can't see it. I can't move it. So first off, the exercise. This is going to show the patient how to do easy exercises that they can do to keep up an active lifestyle and work their respiratory muscles on a regular basis. We don't want them running marathons, but walking on the treadmill, riding on like a stationary bike, just lifting small weights and doing breathing exercises while they do it. All of those things can help work their muscles at a safe level. Second, the education programs, they can teach the patient the importance of following their medication regimen, teach them the importance of smoking cessation. There's a lot of different options out there. We can reteach them how to use their delivery devices. So if you don't do an inhaler the right way, then it's not going to work. The medication's not going to deposit the right way. You're not going to see the full benefit of that medicine. So things like that can help them stay out of the hospital as well. Breathing retraining. For someone who is living with COPD, it's almost like they have to relearn how to breathe only through a smaller tube. It's like trying to breathe only through a straw, which actually at my pulmonary rehab rotation, she had me do that while we were doing our exercises. She made me sit down and do the exercises with a straw in my mouth, and that was the only way I was allowed to breathe. And it's really hard. It makes you not want to exercise because you get out of breath so much easier, and it's hard to get your breath back when you're breathing through a much smaller tube. And the next, chest physiotherapy and airway clearance. This one's a big one because, like we've covered already, they have an excessive amount of mucus in their airways. They need to learn the importance of getting it up, of making themselves cough. Otherwise, they're going to end up with pneumonia. They're going to end up in the hospital, maybe even have an exacerbation because they aren't clearing their airways well enough. So keeping them up to date on that is going to help them stay out of the hospital as well. And then next, mental health support. COPD is lifelong. Once they're diagnosed with it, they're going to live with it for the rest of their life, and it's debilitating. As it progresses, it gets harder and harder for them to keep up the same quality of life, to still exercise, to want to even leave the house sometimes. So it takes a toll on the patient's mental health, and they can end up depressed because of it. And so we want to make sure we're not only taking care of their lungs, but also taking care of their mental health, doing whatever we can to help them stay positive, to help them stay in pulmonary rehab, because it's nice to be able to be around people who understand what you're going through. Like, we as the healthcare providers, we can understand it to an extent because we know what's going on in their body, but being able to meet weekly with people who are also dealing with the same things that you are, it helps bring like a little bit of positivity to a really, really sad situation, because at least you're not alone. You have people you can talk to about it who understand it on a firsthand level, and they can share tips, things that they've learned that have worked for them, or things that they've learned that they don't need to do to stay out of the hospital, things like that. So that one's a big one as well. And then lastly, nutrition. This can play a big role in whether or not the patient stays out of the hospital. Their diet specifically. We don't want to put any strain on their heart because there's already so much strain on their lungs. So We don't want them taking in a ton of extra fluids because we don't want their system to back up and their heart to have to be pumping out extra fluid. We want to limit their sodium intake so that their heart's not having to work double time. These are small things that can help keep them out of the hospital as well. So then next, symptom control. For treating the exacerbations, when someone comes in with an acute exacerbation, we're going to focus heavily on giving them the regular doses of short-acting bronchodilators. So you're going to see those Q4 treatments of your short-actings, so that we aren't letting it get bad before we treat it. The continuous supplemental oxygen, obviously, you're going to do that to keep their SpO2 between 88 and 92. You aren't wanting to keep them at 100 because they are a chronic CO2 retainer. Antibiotics, if there is bacteria causing the exacerbation, systemic corticosteroids, if it's a very bad exacerbation and nothing else is working, you can use those steroids to help reduce that inflammation. And then if it gets to a certain point, you can consider non-invasive or invasive ventilation, so BiPAP or putting them on the ventilator and intubating them. And those would be indicated if the patient's got respiratory distress that is worsening and headed toward failure, if they've got a worsening acidosis or hypoxemia that we cannot get under control. So then monitoring their symptoms, you're going to want to monitor their pulse oximetry, make sure that SpO2 isn't falling too low or even getting too high. Monitor their FEV1 and worsening shortness of breath. That's a big thing in pulmonary rehab as well. They will ask them at the beginning of every session, what's your shortness of breath today? And there's like a little chart on the wall that they can tell them about. And getting regular spirometry tests to make sure that FEV1 isn't falling rapidly. Monitor sputum changes. If your sputum suddenly has a green color and it smells really, really bad, you might be coming down with an infection in your lungs. Monitor for the increases in coughing and wheezing. Monitor for frequent morning headaches and dizziness, and that could be because overnight they've been retaining more CO2 than usual, so they wake up in the morning with a headache. And then also monitoring for signs of infection, so like fever, chills, sputum changes, things like that. We want to make sure that we're keeping a good eye on the patient so they don't get worse before we realize it. Then next, oxygen therapy. Like I said earlier, the goal for COPD patients is to keep that SpO2 between 88 and 92%. If they're sitting at 98%, we might be knocking out their hypoxic drive. So you want to make sure that you are keeping them at that safe level, seeing as they are a CO2 retainer. And if they require long-term oxygen therapy, um, these are some of the things that they could have that are getting them the criteria for long-term oxygen therapy. So they might have a very severe airflow limitation, which would be less than 30% of their predicted FEV1. They might have severe cyanosis. They might have polycythemia, peripheral edema, raised jugular venous pressure, or an SpO2 lower than 92% when breathing room air. Also, we have the option to give ambulatory oxygen therapy, and that's for patients who don't necessarily need it to go about their daily life, but if they exercise, they might need it. Maybe when they start walking outside, their SpO2 drops down to the low 80s, so that would be a good reason to give them oxygen, but otherwise they're perfectly fine and sit in that good margin that we like to see them in. Ambulatory oxygen therapy is often seen in pulmonary rehab programs because they are exercising and maybe that's truly the only exercise they're getting. And so then lastly, surgical interventions for COPD. There's a couple of different options. One of the big ones we see is the lung volume reduction surgery, where they will remove 30% of the most diseased lung tissue, and this allows the remaining lung tissue to work better. It doesn't cure COPD, but it can improve their exercise capacity and quality of life, especially in those emphysema patients where we're seeing their hyperinflated lungs. Maybe helping cut off some of that lung tissue will help them not hyperinflate so much that they can't get the air they take in back out. And then the next one is bulectomy. We've all heard of blebs or boulets as they're called, and I have a picture there. You can see right here what the blebs look like. And then in this surgery, they just go in and remove those really large blebs, but this one's rarely done because they have to be very, very large to qualify the patient for this surgery, and you don't typically see that. And then the third option is lung transplant. This one's drastic, and it's only going to be considered if they are not a candidate for lung volume reduction surgery, so that tissue damage can't be repaired by other surgical interventions that we could try. Um, so for them to not qualify for the lung volume reduction surgery, they would have to have 3 or more severe exacerbations in 1 year. Severe meaning that they ended up on a BiPAP or ended up intubated because everything else we tried didn't work. So that's all I have for this last video. And just to review, we talked about pulmonary rehabilitation, the benefits of it, and what you can expect if you participate in pulmonary rehabilitation. We talked about symptom control, so how you treat exacerbations in the hospital, and also what they can do to monitor their symptoms at home. We talked about oxygen therapy and the requirements they may need for that, and then also what possible surgeries we can do to help improve their quality of life. So then there are my references. It was 2 pages this time around. And then I have a thank you page. And that's all I got for you.